Good afternoon. Thanks so much, Aaron, for getting me involved. And this is really quite a topic that I'm passionate about. So I'm very happy to talk about how to put the hernia surgery on a protocol. Again, this is my disclosures, not pertinent to this talk. So when we look at factors affecting outcomes in our world. So certain things we have little control. Practice profile, case mix, yes, we can subspecialize, but I think at this point, kind of things that come through the door, at least in my world, I have very little control. We do have some control of operating room facilities, some equipment. We definitely can build the team around us, and that's great, but again, not full control. The most control we do have is what surgery to do, what surgical techniques to apply, and we also have essentially full control over our perioperative care plans. And the most important thing to really emphasize on all of this, regardless of the control that we have, we want to have diminished variability to optimize outcomes. And the concept is not new. As you can see, it's from pretty long ago. We've gone through this early stage automobiles to airplanes. So the concept of a conveyor or sort of predictable, reproducible steps is valid in many aspects of life. Enhanced recovery pathways have targeted stress response. If you really see everything we'll do, will minimize the impact of surgery or an intervention on a patient. And there's multiple things we're going to do to accomplish that, which will start off preoperative education, post-operative acceleration of intestinal recovery, obviously optimal pain control, and at the end of the day, this will result in maybe unexpected metrics, but kind of shorter recovery, better recovery, less complications, and ultimately cheaper and more lean care. So how do we optimize patients to prevent postoperative complications? Again, if you really break it down, we have simple patients, or we have, complex patients that we want to have the best chance for recovery, but it's also important to take a quote-unquote routine patient and not move them to the group of complex patients. And really, if you do a lot of complex hernias, you will notice that somebody who has a really bad multiply recurrent hernia, possibly an infected field, started off relatively easy, umbilical and epigastric defect. They may not have been fixed with the right approach or the right mesh, or despite the best efforts, developed complications that ultimately led to a number of problems. So very important to not view simple hernias as routine and not be thorough about those patients as well. Again, hernia repairs are on the top of the list for complications, so we have to take them seriously, no matter how clean or straightforward the case looks. We made first attempts to create a particular enhanced recovery pathway for hernia patients, and this was our pilot study was published in PRS, and again, it's critical, and Eric just went over some of these factors. It starts not on the day of the operation. It starts when you begin to contemplate surgery. Your pathway begins when you contemplate booking, not even when you book the case. Smoking cessation is key. I won't spend too much time, but it's well studied. It's not voodoo. It's studied really well. Don't give in. Wound healing and infection surgery is linked to smoking significantly. There are multiple studies that looked at how long, and I'm going to spare you the multiple investigations. It's 4 weeks. It's no less than 4 weeks that we should demand smoking cessation in open repair. And for those who refuse or can't, and they have escalating symptoms, and I think a lap ventral might be an alternative to get them out of the obstructive kind of emergent situation, but ultimately I stay away from formal reconstructions in those people who are not optimized, and smoking cessation is one of the most optimizable interventions we can attempt. So our approach, extensive counseling. I also don't tell people, quit smoking, come back when you're ready. We give them benchmarks, we give them time frames. I spend actually a long time. It's not a kind of visit that I just assign my nurse practitioner or resident or fellow to just let them know to quit smoking, come back. I go in there and I tell them why. I tell them it's not because I'm worried about lung cancer. I tell them one cigarette is going to reduce your cutaneous blood flow by 38%. That's data. And that resonates with most people. I will tell them every time you smoke, we kill the little blood vessels that we need to heal your wound. You explain to patients why, and because they've heard about quitting smoking all their life. So you explain to them why, and believe it or not, a lot of people will listen. So they promise to quit. We test them. If they test positive, they get a little penalty, so they get delayed. If they try to sneak around the second time, they get fired from the practice. And I can tell you, people do take it seriously. If you have somebody on the schedule, they said they quit smoking or they're quitting smoking, we book them 2 months ahead, they will call and say, I'm sorry, I had a couple of cigarettes, I'm almost there, can you push me for another 4 weeks? They will participate in this care. And that's the kind of patient you want who's going to be a team player in this regard. Again, 4 weeks minimum. Nicotine replacement is acceptable because I don't think it does the same thing to the cutaneous blood flow. E-cigs we're against because we just don't know what's in it, and it's unacceptable. Nutrition, obviously good nutrition is key. Optimized nutrition, don't operate on malnourished patients. Don't operate on patients who may be just getting into the range of things that for pre-albumin that seem acceptable. It's incredible how easy on post-op day 1 or 2 you're going to take down a complex fistula. The person was seemingly optimized and their pre-albumin is going to be down to 6 on post-op day 1 or 2. I learned this, so somebody gets into the normal range, their CRP is down, their pre-albumin is up, and I want that to be for another 30, 60 days at least. You're going to keep them on that well-nourished stage for a while, otherwise they have no reserve, and it shows up early on in post-operative period. Nutritional manipulation is also very cool. This is, again, a very quick slide about immune nutrition. Arginine and ornithine are conditionally essential amino acids, and they're relatively depleted in the states of stress and trauma. And this is really has been shown in multiple prospective randomized trials to help to reduce infections, to reduce hospital stay, to really improve multiple parameters. And the fact that it's not the standard of care for most surgeries is still so surprising to me, and it's really sort of needs to be addressed. Again, low albumin is a deal breaker. Even well-nourished patients will have this arginine depletion after stress of surgery, and it may affect their collagen synthesis. And again, arginine omega-3 can blunt the effect. Our approach, we give this drink no affiliation with the company. We find this very useful. It's about $50 on Amazon. Not every pharmacy carries it. Most patients will not spend that amount of money, even though it provides all those benefits. So in our hands, we put all these boxes in pre-admission testing area. When they go for anesthesia clearance, they get the supply. It costs us $50, but if we can reduce complications and improve length of stay, it's almost money well spent for your institution. Okay, so this is 3 drinks per day, 5 days before surgery. We joke on the morning of surgery that they're supercharged, and people really like this. Diabetes control, Eric mentioned a lot about it, so I'm not going to talk too much. And I'm sort of with Eric. What's the number? And I use 8, and now I'm using a little bit more, close to 7.5 as a deal breaker. 8.1 is not acceptable. Okay, so make that one number. Don't let somebody say I want it at 8, but like I'm 8.4, 8.5. No, it's closer to 7.5. 8 is less than 8 is a deal breaker, or more than 8 is a deal breaker. You can rely on PCPs to manage it, but really those who are over 9 or 10, their PCPs have failed, or the patient has failed. This is unacceptable for their life, and not just surgery. So we get an endocrine consult, and definitely be strong, and don't let uncontrolled diabetics get an incision. Weight loss, obviously we want everybody to be skinny and fit, and that doesn't happen, but obesity is the #1 patient-modifiable risk factor predictive of complications, no question about it. Self-diet doesn't really work. We have tried Atkins Diet for this early non-sustainable preoperative weight loss. That could be useful for those who need to lose a lot of weight. Don't tell people to lose 100 pounds and come back. That's a surgeon speak for see you later. It doesn't work. We set goals. I see patients every 3 months, and it's just the way it is. We have a medical weight loss specialist in the area. He does an endocrine assessment, puts people on this protein-sparing modified diet, almost like a healthy Atkins, and we've had good results in those people who went there and were motivated to succeed. And people who were not motivated and who didn't go, whose insurance didn't cover, were not successful. But it's one of the tools. Figure out in your area who can help you with that, and that's going to be useful. Our data, however, suggests, and we're going to present this in 10 days at the AHS, that the cutoffs for weight loss, what's the line in the sand that we can't cross? Obviously, if we can keep them non-obese, we're going to be great. But the next break for me was BMI 45. So the number 40 gets thrown around a lot, but it's really not based on particular evidence. It just kind of seems, but I always said, is 38 okay, but 42 is too much? Because a lot of times, it's not clear, especially in women who have a different distribution of body fat. It may not be as important. So my line, in a sense, based on our own data, is 45. I will try not to do, except for in some exceptional circumstances, elective abdominal reconstruction for somebody with BMI over 45 because of high wound complications. It's not actually critical from the recurrence standpoint. I can overcome obesity by using heavier mesh, getting more overlap. I'm not afraid of recurrence, but I work harder myself. It takes longer. There's going to be more perioperative systemic and wound complications. And does the price justify the means? I don't know, and it's tough, but 45 is my little cutoff. MRSA eradication, again, bottom line, universal decolonization for all our patients. It's been shown to be most effective, and that's what we do. Again, this is the level of evidence of things that I just presented to you. Most of them have really good evidence to implement. So that's a good idea. I'm not done yet. I still have 3 minutes. So just quickly, what do we do? There's another important thing about intra-op. This was all just pre-op. We use, I'm going to say Entereg, pre-op, gabapentin, and I utilize tab block. I still have about 3 minutes, so I'll go through some of the details of my actual ARS, Enhanced Recovery Protocol. Notice there's a multimodal pain control, and there's an emphasis on the acceleration of intestinal recovery. You can see we emphasize non-narcotic medications and early feeding strategies. We also emphasize early mobilization with very structured post-operative physical therapy, and also very judicious fluid management and early HAP blocking, and really less fluid is better. Pain still continues to be a major factor. We have used epidurals but abandoned because we got inconsistent results, significant fluid requirements after high thoracic epidurals, and honestly, our patients were not getting great control. If your hospital does a good job with epidurals, great. Ours didn't, and we relied heavily on systemic narcotics, obviously with multiple complications. Again, gabapentin, tab block intraoperatively, and post-op multimodal regimen is the way we go. I looked at our utilization of tab block with long-acting liposomal bupivacaine. This is now published in American Journal of Surgery. You can see this is the usual system with dilutions that are recommended by the maker, and the transverse abdominis plane block can be done in multiple different ways. If you do a lot of transverse abdominis releases, that operation lends itself very nicely because I'm looking at that plane, I'm looking at the cut edge, so I can instill liposomal bupivacaine right into the correct plane. If you don't do that, if you do a laparoscopy, or you're doing a lot of anterior component separations, or you're doing anything else, you can do this with ultrasound guidance or under direct vision, percutaneously, again, instilling it into the correct plane. It has to be where the nerves run, which is between the transverse abdominis muscle and internal oblique muscle. for best results. So again, we studied this in 50 consecutive patients matched with or without tab block, and what we found, again, in the matched group with similar hernia defect, we found significant reduction of narcotic use during first 72, kind of 60 hours after surgery, significant reduction in consumption of PCA, or time to oral anesthesia was shorter, and our length of stay was significantly shorter. So we concluded that was a good strategy. We also recently looked at our enhanced recovery pathway outcomes, and we found, again, in a group of very similar patients, because I do the same procedure a lot of times, so it lends to this research, that we found, again, in 100 consecutive patients with or without protocol, in a very well-matched control group, we found that in this group with similar hernias, we found that everything was statistically better. Every little thing that we looked at, time to different diets, tolerating our diet, return of bowel function, time to bowel movement, length of stay, and actually the length of stay of less than 3 days was essentially unheard of before this, and we were almost at 20% afterwards. 90-day readmissions, incredibly, were reduced as well. You'd think you kick the patients out earlier, but they actually come back less often because they get better overall care, less stressful. So why we need ERPs? I think its ability to reduce errors and variability. They definitely improve outcomes. They have improved outcomes and satisfaction of my patients. The key components is optimization, acceleration of intestinal recovery, and optimal pain management. And if you bake a lot, they work if adhered to, and if you bake a lot, you got the ingredients. I'm just giving you one recipe for the cake, but as long as the cake tastes good, stick with it. We'll figure out a different recipe. Thank you very much.
Very fun exercise.